Hello, everyone. Leo Butnitsky with Healthy Technology Solutions here for our continuing webinar series. We have Christian from AR Rescue with us, and we're going to be talking about medical billing and other topics within that realm. Christian, you want to introduce yourself?
Yes, thank you, Leo, for having us on today. I'm Christian Gittersanki, the CEO of AR Rescue. We're a revenue cycle management company that works in the medical billing and coding, credentialing, and contract negotiation sector for healthcare providers.
Fantastic. And why is this an important topic?
Leo, it is so important. I mean, if you go back and think about the amount of education a healthcare professional has to go through, right? You've got high school, undergrad, grad, medical school. Maybe they're doing a fellowship or training, right? They're doing a residency. They can be like, we're talking a lot of years of education, right? And then an enormous amount of financial investment. And then, a lot of times I think what happens is they're just so relieved to be done with all that, start their career. And I think what happens a lot is that they fail to understand the whole business aspect behind healthcare, right? They're like, I'm a physician or I'm a healthcare professional and a provider. I'm going to get paid well. And it's just not the case. And it's interesting that you ask that because most of the time we find that it's the one profession that the professional really doesn't know what they're due, right? And how much they should be asking for. And they just start seeing patients and think, well, the money will start coming in. And but they just don't really have a clue on how much they should be getting paid for their time.
You never hear about engineers or attorneys having that problem.
No, not at all. Everybody knows their rate of pay when they go into their job, right? Or their career when they first start, before they even do day one, right? You know what you're getting paid. And physicians and healthcare professionals are just happen to be that one profession that really doesn't know most of the time.
Okay. Well, before we really get into the meat of it, I figured we would briefly talk about why an IT firm is having this conversation with a medical billing expert. And part of that is because, and I apologize for my voice, I just getting over a cold. But my company, Healthy Technology Solutions, a big part of our business is working with healthcare organizations. And the success of those healthcare organizations is really, our business is dependent on the success of our clients. And so if our clients are not getting paid, that means eventually we will not get paid. So this is a pretty important topic for us. And also, I mean, a lot of our clients are, we care about them. They become friends. So we want to make sure that they get paid what they're supposed to. And just real quickly, kind of go over what we do. It's, who I am. I do all kinds of stuff. Love to scuba dive, travel, and a bunch of other stuff, search and rescue, and technology. We do the gamut of everything technology related that doesn't require making pretty pictures or writing code. So we're infrastructure, we're the help desk, phone systems, cybersecurity, all that stuff. And a lot of that includes HIPAA. We don't do medical billing, and that's why we're talking to you, Christian. This isn't really about me, but I figured it would make sense for people to understand what we do. And I'll put the slide up at the end. But for now, I'm going to stop sharing and really start talking about medical billing. Why is it important? And what are the big fallacies and misconceptions? And why is it that healthcare is the only industry I know about that people don't get paid properly for what they do?
Yeah, well, there's so much money going around healthcare that it's, all the players involved when you talk about providers and insurance payers and the government, everybody's got their hand in it and hand out for some money, right? And so it's just a big business. And with big business comes complicated minutia you have to work through to get paid. And I think at the core of it, though, like some of the big fallacies behind it, it's not just, hey, I see a patient, they have health insurance and I bill that claim and I get paid. there's just so much more nuance to it, that I think providers kind of go along and they have misconceptions about how the system actually works. And that's really what I kind of want to focus on for healthcare providers is how do they navigate that without having years of education and experience behind them on how to do that? What can they, what's some good takeaways for that, right? And so, like, especially like the last several years, CMS, right, which is basically that's the national entity, if people don't know, right, that engages all the rates, the types of services. They're the ones that everything really starts with, and that's Medicare and Medicaid services, right, for the whole nation, and then Medicaid is specific to a state. But they're really the ones that set the standard for all the other payers to follow on whether they're going to pay for a claim, how much they're going to pay for a claim, and what kind of hoops they want the providers to go through to get paid on that claim. And so, with the addition of like services like chronic care management, principal care management, remote patient monitoring, cognitive behavioral assessments and therapies, right, with neurotherapies, there's all this new technology evolving, and you can speak to that too every day, right? Every month they're coming out with new treatments and diagnostic tools and testing. And so I think the first fallacy is that a healthcare provider typically just assumes that's going to be covered, right? If it's out there and there it's a payable code now, right? It converts to a CPT code and we bill that, and that's how the providers get paid. They just assume that, well, it's payable and I can do it. And so that's probably the biggest single fallacy that we see is that sometimes providers will start engaging in these services for patients because it's good for patient care, right? It has better patient outcome data and all these other things that all these buzzwords, right? Um, but the fact is that if they don't go to the insurance payers and go, hey, under this, I'm a primary care or internal med doc, and I need to know if I can actually provide this type of service. They'll come back and say, well, it's not included in your agreement that you currently have, right? And I think that's where it's really important for the provider or the provider's office to engage the insurance payer and say, hey, I'm credentialed to do a panel of services. And if those panel of services don't include these new codes, I need to have an addendum to include that. Or the payer could come back, right? A Blue Cross could come back to a provider and say, yeah, but you know what? That's really meant for a pediatrician, right? Or OBGYN or a pain management specialist, and we don't want you doing that. So it helps, I think, that communication too between the payer and the provider to understand, hey, what can I do? What are some of these new codes coming out? And then how do I best, right, work with my payers so I can get paid for my time?
Interesting. No, that's great. That's great information. What about the issue? So if I'm, Dr. Smith and Dr. Jones are down the street from each other, and they've been practicing medicine the same length of time and working with the insurance company the same amount of time, or maybe one is brand new and the other guy's been there for 10 years. Are they going to be getting paid the same amount, or what determines their pay rate and at what or reimbursement rate, and at what point do they need to reevaluate that? I mean, and how does that process work?
Yeah, no, that's an excellent question. And the short answer is no, they're not paid the same. And, there's an actual law against collective bargaining with physicians. You can't, that provider, you can't go together and then go to the insurance payer and say, I know what this guy makes and I know what that lady makes, and I want more money, right? And so I think as a professional that deals with multiple specialties, it's important to have somebody, right, to collect that data from all sorts of different sources. There's Consumer Fair Health as well, which you can type in a CPT code, the zip code that you're in, and see what the average, and this is millions of claims data that was compiled for this reason. They can get an idea. I'm an orthopedic surgeon. I want to do this procedure. I'm in this zip code. This is the average rate that another provider like myself gets paid. Here's the high, here's the low, here's the cash pay price, here's the in-network and out-of-network rates. And so I think that helps hone that down. Those are some tools that a provider can use now on their own, right? Just to get an idea. But yeah, it's really interesting. One of the big things we see are most times practices that have a longevity of 10 years or more are getting paid less than providers coming right out of school. And that's
Wow.
because it talks to that second part of your question about, well, what can you do? What is there? It's engagement with the payers, right? A lot of times you come out of school, you sign an agreement, you're like, yes, I've got Blue Cross, I've got Cigna, Aetna, Humana. At least they offered me an agreement, right? Not really sure how the pay falls, but at least I have an agreement and I can start seeing patients. That's only step one. Step two is, well, then am I getting paid well? Right. And as longevity, right? I mean, it's that whole thing about experience, right? I'd rather probably see a physician or a surgeon that's got 10 years under their belt. But the problem is that doesn't ever keep pace with cost of inflation, raises, the complexity of navigating healthcare for a provider. And so they never go back to the table with the insurance payer, and they've accepted that rate in year one. And they had maybe, most contracts are 1 or 2 year agreements. They've missed a minimum of 5 times to renegotiate with that payer. And so
Wow.
that's how that happens. So a physician that has much less experience could be getting paid more than one that has more.
And so who typically is doing that job within so if it's a small practice, who would be doing that job if it's a one, two, three, four, five provider practice? Is anybody, is it the practice manager? Is it the billing? Is it the biller? Does it even make sense for them to be doing their own billing? That's, because I see that the whole gamut. I see small practices doing their own billing. I see large practices outsourcing and vice versa. What makes sense? And at what scale does it make sense to have in-house? And what's your opinion on that?
Yeah. So, you know, this is my 30th year of doing this. And so I've seen
Oh, so you're
all
brand
kinds
new.
of different structures. Yeah, 30. Yeah, 3 decades. So I had kind of ages myself, but um, we see all sorts of different people doing it. We've been in practices where the biller is trying to do the credentialing and stay up on the contracts, right? Because every year or 2 years they have to recred with that same company, and so either the insurance payer just offers them an extension with a lot of fine print that nobody reads, or they have to actually re-engage them and get re-credentialed, right? Providing them new updated information and malpractice and all these things that are through CAQH. But um, typically we've seen it done, it should be done by like an admin level or higher that has experience doing it. Because again, this is like the most neglected area of a practice and the most important. How are we getting paid and how much are we getting paid? And so if you leave it to somebody who has no experience to do it, you're going to get the results of somebody with no experience doing it, right? Well, which means that most of the physicians out there are typically underpaid 15 to 25% of what their value is. And so I've seen it work in both models. We're an outsourced RCM company. I think there's a benefit to that in that we work in 36 states. We serve almost every type of subspecialty and specialty out there. And so we have a breadth of information internally that we can use to do that. By contrast, you could use a credentialer or a contract negotiator. There are two different things too. Credentialing is not the same as contracting. Credentialing is all the paperwork, right? All the minutia and the paperwork to fill out. Contracting piece is when you're getting in there and you need somebody who's going to be a warrior for you and fight to get you more dollars. And that is, I've not seen that work well with just, entry level billers, in-house people. They just don't tend, that's again, it's the last focus of a practice, should be a primary on the financial end.
So for just to, maybe to throw out some real numbers. So let's say for a typical, say two provider practice, it's just primary care. Let's just look at primary care. What can that mean to the annual, difference in annual revenue?
Well, for primary care, you're talking a minimum of 15%, a minimum. And we've engaged, and this is just from our experience, we've engaged some where we've been able to top out at 35, 40% more revenue just based on that model, right? Just on that change. And I think here's the other key point with contracting as it relates to billing is that every year CMS comes out with new regulations and changes. They're released October 1st for the next year, right? I can't tell you how many practices we see they never update or implement those updates. So, and what does that mean? It means, well, the pay might change. Again, that red tape, that minutia might change. There might be new rules in place for prior authorizations or whatever, or referrals. There's all kinds of things. They may have a replacement code. Maybe they deleted a code this year and are replacing it with a new code. We've seen practices that'll get 6, 9, 10 months into the following year, and they're still using an outdated code. And so again, it just lends to how important it is to really have a pulse on that.
Wow. No, and it's when you're talking about 15 to 30%, that's a complete change in quality of life for the practice as well as for the providers themselves. But with that, not every dollar has to, necessarily goes to the doctors. That means, people in the practice can get paid more, better staff can be hired, better patient care, better equipment. I mean, that's a huge difference when you're talking about, across you know 70, 80 patients a day, over 300 and whatever days of business days that they're open.
Oh, it absolutely is. It's sad that I hear that a lot, is I'm just trying to keep my head above water and keep the practice on track. I don't hear excitement about reinvestment into their own company, their own people, processes, equipment, security, like all these things, right? You have to keep up and be able to continue to evolve in those aspects. And I think that extra, even if it's 15%, is a huge amount, right? If you take the average practice doing 100,000 a month in revenue, I mean that's a game changer for most practices, right? And if you've got 5, 10, 15 providers, think about the impact you can have there. And I think it's just super important for them to understand that aspect of it, that it's not just like you said, it's not just to line your pockets. It's part of it is reinvestment, right? What if you want to do a in-office surgical suite, or you want to buy into a surgery center and you're just kind of scraping by, right? A 15, 20, 25% uptick in revenue is going to be huge. And I'll say this too, on a personal note to healthcare providers, is I mean, let's work smarter here, right? The answer is not always patient volume. It's very rarely patient volume. There's plenty of patients to go around for providers, but it's kind of like, doc, do you want to work a 16-hour day or a 10-hour day and enjoy your family and enjoy life, right? Enjoy some of the fruits of all this labor. And I think that's where the real freedom comes in for them as well.
No, I mean, that's an extremely important point, because I know from a standpoint of, for years, it's like I've been doing this pretty close to almost as long as you've been doing this. So I've been in
Yeah.
IT since, 96 or 95. And for years, I wasn't properly billing, didn't have proper contracts with clients. And while the clients got served, I and my family did not. So
Right.
figuring out how to properly do that really is critical in order to be able to have a successful business. Because if my business is not successful, I cannot properly take care of my clients. If I've got personal financial stressors, and I'm hiring people because they're inexpensive as opposed to being the best, that's the quality, of service that I'm going to provide my clients. And the same thing for patients. So if the doctor's not hiring the best medical staff, the best mid-levels, having the best diagnostics equipment and everything else, and they've got to run through more patients every day, then what happens to the quality of care? And where they would not have to see as many patients, they could spend more time with each patient. So there's so many different benefits to getting properly paid.
Yeah, there
Even for
sure
the
are.
community.
Absolutely. Yep.
So I think that's absolutely fantastic. So you guys are doing God's work.
Yeah.
I
Yeah. Kind of
mean, in
hard.
all
I mean,
reality,
honestly, it's really important. And I just think there's just a number of things that healthcare providers have or they've heard from their colleagues, right? who also aren't negotiating with payers, right? If I go engage a payer, they're gonna terminate me. They're gonna drop me if I ask for more money. I'm like, there's just not even any, there's no truth in that, right? Unless you go and you're just an aggressive bull in a china shop with them, they're not going to do that, right? They are actually looking forward to engagement. And there's resources, I think, for providers they don't use. There's provider liaisons with all the commercial payers, right? Those are liaisons. They're hired by the insurance payer to engage providers, right? To have an impact on communication, impact on patient outcomes, and they're the person that every provider should start with if they're going to try and do this on their own. I mean, that's what we do. We work with them all the time. And some of them are more responsive and helpful than others, but it's a starting point, right? For them to take. Because a lot of times there's just these different fallacies that providers have in their head that just aren't true. I mean, they think, well, do I need an online presence? I don't need an online. What do I need a social media page for? I'm not trying to do that. Super important because you have one whether you want one or not. If you search your name as a healthcare practitioner, you have ratings out there, right? And it's better to be engaged with them and understand them and take control of that than to just sit back and hope for the best. Most of the providers I go, I don't really even realize I had that. And you go on, and most of them average 2.5 to 3.5 stars if they're not engaging in that, right, that relationship with their patients. And they have no idea. They're like, I had no idea. That's not great. And I think the other thing that's important here is there's central databases for data for providers. There's CAQH, which is like the gold standard, right? Every provider needs to upload all their information. They have to attest every quarter. And then the insurance payers pull that data from them in that underwriting process, which is credentialing. So that's why they have to attest every quarter. Well, there's another a database, which is the NPDB, which is the National Provider Data Bank. This is another central repository for provider information, but it's much more personal and it includes personal, professional, civil cases, arrests. I mean, things that providers would think there's no way this is going to be out there floating around. If you've done it, it's probably in the NPDB. And so it's important. It costs $3, okay, to do a self query as a provider on yourself. Super important to do that and pull that quarterly because we've had providers come to us and they're like, I've lost 3 contracts in the last year, and the insurance payer won't tell me why. And we pull an NPDB on them, and we know why, right? It's usually very glaring. There's an issue there. Sometimes that stuff can be reported there in error, but I think the bottom line is that however you engage the payers, being upfront and honest with them about your situation, your background. If you had a big malpractice case this year, disclose, disclose, disclose. They get really, really not happy when they find out about it and have to come to you with it, right? Rather than you being forthcoming about it and just saying, hey, this happened and here's the situation. I mean, common sense, really, when you think about it, because that's how you want to be treated with other people too. But that's what the payers look at. And so that's really an important aspect.
How much does some of the legislative changes that happened last year here in the state of Nevada, where we're currently, I think we're both sitting,
Right.
where they've increased the med mal limits, as far as the med mal limits that the courts can award, and and then the attorney's fees are outside those limits. I mean, which means that the medical malpractice insurance is going to increase. But if the providers are not, if the practices are not properly getting paid, how do they even stay in business? And is that going to cause doctors to flee this state? And this happens in other states as well. So can you talk a little bit about that?
Yeah. Sure. Yeah. Provider retention, huge, huge problem, especially for the state of Nevada. We're one of the worst on retaining talent here, right? A lot of times we have some great teaching universities here now. We'll train them. They'll do their, they'll do their residency here, and then they'll leave. And that's kind of a sad state of the way it is. that's a really great question. The med mal impact. It's sort of calm waters a little bit. I think the bigger impact right now that we're seeing is fraud cases and data breaches, fraud, um, and behavioral health is one of the worst. Well, I want to say it is one of the worst. It is the worst in this, at least the state that we're in. It's the worst in this our neighbor, right, Arizona. Also, just had a $1.5 billion fraud case last year. They had to settle through the state of Arizona through Access. It's a huge concern and a huge problem. And I think, part of all of this goes back to that those fraud cases, they cost somebody money, right? And so they cost the taxpayer money, but I think more importantly for this discussion, they cost the provider money. So there's less money to go around for raises. There's more scrutiny on what they do, and they better do it right, right? Or they're not going to get paid. And so I think that's where all those things tie together really importantly. Having a good online presence, having excellent security and digital security in place, right, to protect these patients' data. I mean, we all know about Change Healthcare. I mean, everybody
Absolutely.
who's, I mean, people not in healthcare know about Change Healthcare hack, right? We've had that issue. We've had tons of PHI being exposed from different providers. So I think, you know, it's tough when somebody says, well, what's the one or two big things impacting, right, these reimbursements? I'd say that's one of the biggest things is fraud. And if you can illustrate as a healthcare professional, you've taken steps, right? You've proactively taken security steps with IT, infrastructure, internal training, compliance manuals for your employees, all these different things. And you go to the carrier with that and say, look at all the things we've done to ensure that the money you pay us it doesn't just go somewhere, it doesn't get burnt, right? This is going for patient care like it's supposed to. I think that's a huge thing. And very few providers are doing that right now, and they should. But I do
Oh, yeah.
understand, right? When billing's not going well, there's not extra money to invest and reinvest in good IT infrastructure, training, compliance. Those are the things that sadly they just kind of fall along the wayside. And then it's a bad cycle, right? Now they're more exposed, they have more issues, and on and on.
So I mean, this kind of plays into what we do. We are constantly trying to explain the importance of, and we actually even provide every one of our clients, we provide a minimum level of cybersecurity awareness training to their employees. Only about half of our clients take us up on it. We're providing it for free, but they're looking at it as, hey, this is 45 minutes that we're going to have to pay our employees that they're not going to be working, not being doing something for us. And I'm explaining, listen, if they click one time on the wrong thing, and most of our clients we have locked down pretty well. And actually, the clients that refuse that, we won't take on anymore because we have some risk as a service provider, as a business associate to those practices. I don't want to be in the newspaper for anything bad. Or on TV. I don't want CNN vans in front of my house because
Right.
one of my clients had something bad happen. There's in regards to fraud, I was at an event not that long ago where some of the investigators for the state of Nevada Medicaid fraud were talking, and one of the providers in the room asked them, "Hey, what percentage of the total Medicaid budget do you think is fraud?" And the guy kind of thought about it for a second, said about 75%. And that's astonishing. That means three
Yeah.
quarters of every taxpayer dollar is being stolen by some dirtbag. And I'm okay if I feel totally fine referring to them as dirtbags because I mean you're stealing. I mean, if you're stealing, you're a dirtbag. But
Yep.
this is you're stealing, and there's less money available for the most needy, and less money available to those that support the most needy. So that to me is just mind-boggling. And then, on the IT side, yeah, you hear all about all these big breaches, but what you don't hear about as much is the smaller practices because it is not as, it's not as many people affected, so it's not front page news, CNN or Fox News. But who is more easy to compromise? Um, you know, Change
Yeah.
Healthcare or HCA or Bob's Pediatrics, because Bob's Pediatrics has 10 employees, none of whom are in technology. They may or may not have a company like mine that's covering them. They are much easier pickings because even just not even using technology, just basic social engineering, calling up and pretending to be from the EHR vendor or from IT or from the state. And most people, when they answer the phone, they, even if they're busy and haggard and really have a bad attitude, most people, if someone nicely approaches them, want to be helpful. And that's the problem. That's how social engineering happens. And MGM was the same way. If MGM can
Yeah.
get compromised through social engineering, and now with all the AI tools out there, you don't have to be a genius to be a hacker. You can be completely computer illiterate, and you hire someone to do it on your behalf. So there's so many risks. So on one side, the practices are not spending enough on IT and security, but on the other side, they're not getting paid what they could because they're not taking the time to do that. So it's a double-edged sword, and they're getting cut in both directions.
Yes, absolutely. And I mean, you and I have had a few conversations about that. And even myself, going on 3 decades in this field, there's things I hadn't thought about, right? With IT security that I'm like, yeah, this really does play into it. I mean, and like you said, it's one wrong move, right, by an employee that's not trained or doesn't understand any of this, or just has maybe a misconception, right, of what a data breach is. What am I doing? If somebody calls me, like you mentioned, the social engineering behind some of these frauds are just, you know, I don't even know what to say. They're dirtbags who are doing it, but we've got to protect ourselves, and our providers have to protect themselves. And I've always said, when I ask about IT security, because it's like we're the ones that are dealing with their PHI all the time,
Mhm.
right? And so when they say, "Oh yeah, we'll give you access to this or access to that," I immediately stop them and go, well, "Hang on a minute. We don't have an NDA in place. We don't have a BAA in place before we do business together. We don't have, I don't even know what your compliance program is internally. Well, it's Bobby or Sue, my cousin's, kid who's been doing our IT for 10 years. And so we're always up and running and I don't have anything to worry about. Those are the ones that just scare the heck out of me. And I think, okay, they need to talk to a professional like you because it really does. That technology is so heavy now, and with the AI implementation, offshoring, like there's just data everywhere, right? And I think people fail to really look at that program. I mean, honestly, it's one of the, I think, key things. I mean, a lot of the EHRs, right, got booted because they couldn't stay compliant from
Mhm.
the tech side, and so it's very important in our field.
No, absolutely. And actually, a lot of the EHR vendors failed, not even because they couldn't stay compliant, because their revenue model wasn't correct. A lot of EHR vendors were selling systems during when the High Tech Act first came out, and they had great systems, but they were selling systems for, okay, the implementation for this 5 provider practice is going to be $100,000, and that's it. No ongoing, there was no required ongoing costs. And they were thinking, we're going to keep selling these systems. Well, eventually, everyone has a system. Now, where's your revenue coming from to make the changes that are being demanded by CMS, that are being demanded, going from ICD-9 to ICD-10? That's expensive. That's not
Yeah,
free. Each vendor had to pay teams to make those changes. Well, if they don't have money coming in, they can't continue to do that. And so they would either sell or go out of business. And the same thing goes for practices. If you don't get paid, same thing goes for me. Sometimes people will try to
right.
beat us up on price. And it's like, listen, if you want good quality results, you want good staff. If you don't want me to hire my cousin Vinny, who took 2 classes at CSN, and barely passed them to service your account, you want professionals, you got to pay for professionals. Just like patients have to pay for professionals. You can go, somewhere and find someone that's going to pretend to be a doctor. And you hear these cases where, liposuction clinics, or they wanted, I don't know, implants in their butt, whatever the case. And people are putting injecting silicone straight into, I mean, killing people. And it turns out the
Yeah.
person has no medical training. They may be a medical assistant that watched some procedures and they figure, hey, I can do this in my garage. If that's what you want to pay for because it's half the price or 10% of the
Right.
price, that's what you're going to get. You
Yeah.
may die. You may have a big butt or you may have no butt because you're gonna die. And the
Yeah.
same thing goes for your business. You can either thrive
Yes.
or you don't get paid and you get compromised. I mean, we have someone across the street from us, a practice that was compromised. Luckily, they're not a client, but patient plastic surgery. So the plate patients photographs of all their patients before and after breast augmentation surgeries were
Oh,
exfiltrated by the
wow.
bad guys. And when the practice refused to pay, they went directly and started ransoming the individual women who had had the procedures. I mean, imagine the
Wow.
reputational loss, but also imagine how the patients feel.
Yeah.
So
It's
there's a
awful.
reputational cost.
Yeah.
You're hurting your patients. And eventually, there's going to be massive, HHS, Office of Civil Rights fines.
Yeah.
So there's no upside except for the guys that potentially got paid whatever the $5,000 or $10,000 per patient, to take the stuff down if the patient's paid.
Yep.
So there's so much risk. And the question is, how do they want to manage that risk? From a billing side, I think it's a no-brainer. Unless you're a very large organization with a lot of staff, a lot of really quality staff. And that's the problem in healthcare, the constant turnover. We have practices that
Yeah.
call us, that we get 5 or 6 requests per week to terminate people and add new people. I mean, and sometimes it's, hey, these 3 people are no longer here as of now. Please add these 4 other people. And every single week, what is their HR costs? When you have, a couple hundred employees
Mm.
and you're turning over 10 people a week. Um, I mean, training
Yeah.
costs.
Oh, it's huge. You're right. You're absolutely right. I mean, we didn't really talk about that, but yeah, I mean that's a huge problem we see too. Is just I think we're kind of in a sweet spot on our organizational size, right? And how many staff we have, and we have a very low turnover rate. But all of our billers, and I would recommend that for anybody who's going to hire somebody, they should all be CPCs. They should all be certified professional coders. They should all have experience in the specialty they're getting into. That really does make a difference because I think at the end of the day, if you're audited, and now this isn't even a fraud related discussion, but if you're audited by one of the payers, which they are doing more and more now, you need to be able to stand by your biller, right? And if you hired somebody you really don't know the background on, you really don't have a depth of knowledge on what they know, they can code things incorrectly and commit fraud inadvertently. I mean, most of the fraud we see, um, and I say fraud, it's a very strong word, but if you bill it incorrectly, right, and an insurance company pays for it incorrectly, and you never notify them that it was billed wrong, it's fraud, right? They don't distinguish, well, you didn't really know. And ignorance is not bliss when it comes to these situations, and being naive about, well, I'm not really sure how to code that surgery, so we're going to do what we think is going to pay is not that's a scary answer to hear from providers, right? And so I think that's a really important aspect too for them to just understand before they start hiring people and go, well, this guy knows how to build that and it's whatever. It's like, who's going to stand by it in the case of an audit? That's how we look at every single claim that we send out, right? Is it accurate? Is the practice compliant? And then we bill it, right? I mean, you've got to answer those questions first, and most people just don't. Sadly, they just don't.
No, actually, when you bring that up, it reminds me, we had a practice we worked with, a really great practice. They got hit with a multi-million dollar non-criminal Medicare fraud. Medicare came
Mm.
back and said, hey, all these 99214s that you billed over this last 3 years should have been 13s.
Right.
They and luckily the doctor, because I believe if you, I'm not sure what happens if you can't pay, but it's pay this fine now. It's not a payment plan option or anything because we gave you the money, we want it back. And it was a multi-million, he had to write a multi-million-dollar check. Uh, that, for a lot of practices, that would be existential threat. That would be, they'd be done. They most likely don't have the money to refund that. People have been paid. People have been paid bonuses. Have you seen that within, kind of in your travels?
Oh, all the time. Yeah, all the time. And most of the time, what they do is they'll just start taking the money out of your future payments. If you don't have the money for it, they'll take all your future payments until it's paid back. And to your point, right? You made paid bonuses, you paid salaries, you that money's already been spent. And I think the other downside of that is that they're likely going to put you on a prepayment review after that for a period of time. And most of those can last 3 to 6 months is the average. And what does that mean? It means you don't get to submit claims electronically anymore. You can submit them, but now you have to upload all the documentation, all the notes.
Yeah.
You have a whole other layer of just trauma to get a payment out of them, and they will scrutinize then every single claim for those that period of time until they feel that you meet the standards. And so it's like, yeah, it's like a triple whammy. I mean, it's bad news all the way around when they get to that point, but they will get their money back. And those contracts, I think that's, it goes back to that importance of having somebody that's not just a credentialer, but somebody who's a contract negotiator. Look at your payer agreements. They range in size from 18 pages. The biggest one I saw was 126 pages from an Aetna contract. And all the fine print is in there, right? And it tells them they can actually, and here's the really interesting kind of piece of that. Most of the agreements state that even if the physician retires, sells the practice, and they're out, they can still come after that money up to 10 years after that physician is no longer even in the practice. So how does that, I mean, how does that, I don't want to try that on for size. That's not a fun one. But it's true. And so I've seen providers in that same predicament.
So what's your recommendation overall? I mean, you've been doing this obviously a long time. And if you didn't know what you were doing, you would be in a different line of business by now.
Yep.
So what's your recommendation? I mean, what should the average practice do in order to get this under control? I mean, other than to call you and your team, but just what are the next steps that you recommend, that the critical next steps?
Yeah, so I'm going to share. This is just an outline. Can you see my screen? Okay.
Yeah, absolutely.
Yeah, so this is kind of where we recommend people start, right? It's 5 key points, and some bullet points under it, and we're happy to have a discussion with anybody if they have questions like what does that mean? Like, summarizing my practice. What exactly does that mean when you say, well, why paying you more equates to a high ROI for the carrier? That's a lot of these are more in an in-depth one-on-one discussion, and we're happy to have those, free of charge to anybody who's interested. We just want providers to be educated, right? But we found over the years these 5 key bullet points are probably the most important aspects to shore up in a practice. Once they have these, and providers can kind of go through these, and they can answer them, right? Every owner of a practice should be able to answer all these and understand what these mean, right? And so using that information to have that relationship. Again, it comes back to that relationship with the payer. And all of them have a provider liaison. Engage that provider liaison. That's the number one thing. Start talking to the carriers like they're a partner and not an adversary, right? It's they screwed me out of this. They make me jump through these hoops. They cut my pay. They're doing, no carrier is going to want to engage you in a very honest discussion about payer rates when you do that, when you approach them that way. So engagement is the key. That's the number one thing, is to start that relationship with them, because you just that's super important. And I think understanding these 5 key factors is really, I think, at the core of it. There's more to it than that, to the actual negotiations. And I actually have another a more extensive white paper I've written here, uh, contract negotiations in an increasingly competitive market. And it's more in depth on some of these points. Okay. Anybody who wants that can obviously, if they're interested, I'm happy to share both of these with them. Just so they have a takeaway to kind of go, where do I start? Right. And if I have an administrator who's really on it and really knows what they're doing, how do I start that conversation with them? Because they're the ones that are probably going to have to handle this. If a firm like us doesn't, that you need to have that engagement with your administrator or office manager.
No, that makes a lot of sense. Yeah, and from a standpoint of being nice, that helps because I know at least two practices where the doctors, small practices, single provider, doctors were not that nice, and they constantly complained about the insurance companies, and they eventually got dropped by everybody. And with a lot of the insurance carriers, they need more providers in network. And if they're dropping you, oftentimes there's some kind of a reason. Either it's a personality issue, it's a med mal issue, or there could be other things. Maybe you don't want to do things exactly the way they do, and sometimes the doctors are right. So just because someone gets dropped doesn't mean there's a problem with that
Right.
practice, but sometimes there is. So
Yeah.
and so you
Yeah.
don't want to be that guy that gets dropped for a bad reason. If you're practicing medicine the way that you feel you should, and you're getting dropped because the insurance company wants you to cut corners, I respect that. But if you're just going to be trying to be a bully with the insurance company, they are the 800-pound gorilla with a big stick with nails sticking out, like from the Walking Dead. I forget the character's
Right.
name, but
Yeah.
that's you don't want to mess with you don't want to poke fun at or mess with the 800-pound gorilla with a bludgeoning object. Um, so the best way is like what you're talking about is talking about what you're doing the right thing, talking about what you're doing, and and getting your rates adjusted every single year. Because now, if you're 20%, 25% down from where you should be, because you haven't done this in 10 years, are you able to go up 25% in 1 year, or is it going to be incremental?
Yeah, that's a great question. It's likely going to be incremental, right? Because the number one, when we've done that and gone and asked for too big of an ask, they're like, "Why didn't you talk to us the last 8 contract renewals? Like, we can't, we'll give you a raise, but we'll do this in a tiered approach, right? Where we'll give you a little bit this year, a little bit next year. We can get you there, but it's going to be over the course of a few years because kind of on you for not ever asking, right?" And they can't. That's a tough thing to ask them to say, "Hey, boost me 40% because that's where I should be." It's more of a, what do I need to do to get a 40% increase? And I understand that I haven't worked this relationship in the past, and I'd like to now, right? We've changed systems, we've changed management teams, we have a billing team now that is robust. We really want to engage you, and as such, we want to be able to get paid for our efforts, right? And I think that's the approach to take rather than just out of the blue, right? After a decade of being in practice, you go ask for a big increase. And that's a fantastic question. And again, it comes down to strategy, right? How you want to approach those insurance carriers.
Okay, and then what about some of the other money that practices leave on the table by not hitting all the quality measures, by not getting patients in, especially primary care patients that are they have a large elderly population, not getting them in for the visits that Medicare wants to pay for, and things like that. The continuity of care, maybe
Yep.
engaging with, I don't know what your opinion is on accountable care organizations, whether practices should join them, not join them. They can do it themselves, not do it themselves. What's your opinion on that?
I think it's the same thing as everything else. There are some great third-party organizations, some good ACOs out there that I think a provider, especially the smaller practices, can leverage and build relationships with, right? There's some areas and some pitfalls with that too, but I think a good one is actually a solid move in most cases. I think, that I think when it comes down to what you said, and you're talking about reporting, right? When we talk about like macro compliance and all these quality measures, right? What is a quality measure? What does that even mean? Right? Because it's funny, I've had discussions with commercial payers and I've said, look, we're hitting all these quality measures and whatever, and they're like, yeah, yeah, you are, and but we're not sure how to tie a dollar amount to those quality measures. And I'm like, well, this is your idea. I mean, it was the government's idea, right? It's like we want to do patient outcome driven data rather than code driven data, right? Which makes sense. I mean, if you're a podiatrist and you see a patient for a sprained ankle and it takes you nine times to see that patient, you've cost the insurance money X. The podiatrist down the street saw the same patient with the same problem and treated them 3 times, and they're doing better, right? That patient outcome is better. They paid Y, much less. And so there's a lot of nuance to that. But we've had providers where we go to them and they're heavy on the Medicare population, which most primary cares are, most clinics are, right? At least 50% of their population is Medicare qualified age. And we've had some that are already getting 9%, 11%, 7%, 5%, depending on where they were on those quality measures, because they never reported, right? It's a pay decrease of up to 10% or 11% of your total income from Medicare forever. That just doesn't make sense to me, right? And so again, it's engagement, it's understanding. And so I think those are huge holes that practices miss. We've had some where we'll look at EOBs and we'll see that deduction on all those Medicare EOBs, and they had no idea it was even happening, right? They're like, oh, I thought that was for something else. It's like, no, that was for your non-compliant reporting, right? That's a yearly annual thing if you meet the specs that you have to qualify and do it. And it's just part of doing business, you know. Like so
Yeah,
the providers that dragged their feet and said, I'm not doing it. I'm gonna do my paper charts. I refuse to do this. Well, you can do that, but then you're gonna pay a penalty for it, right? And then it's harder to go back to the table and negotiate better rates when you don't want to participate in quality measures, right? I mean, that's a tough sell when you're like, I don't ever meet these metrics and I understand the value of it, but I don't care, is not a good answer, right? I mean, you want to be up on all that technology in the reporting so you can recoup even more money. Now, that was a great
perfect.
question.
Um, I'm gonna put up the slide real quick that, oops, where'd it go? Got so many windows open on my computer that I do not even know um, what, uh, what or where everything is. Um, but I'm gonna go ahead and share my screen with the contact information for both Christian and myself, and see if there's any questions from anybody. And let's see here. Here we go. So we got Christian's contact information, my contact information. We're providing complimentary network assessment or security assessment for anyone that sends in an email and mentions this webinar. Uh, definitely Christian can be contacted there. I would strongly recommend people engage with him because he seems to know what he's doing. And that's kind of important. Because again, if you can get paid even 10% more for what you do, think about, that's life changing oftentimes for a lot of small practices. So, any closing thoughts, Christian?
Yeah, no, just I think we covered a lot of stuff and appreciate everybody attending. And if there are additional questions, we're happy to field them. Like I said, I've been around this business a long time, as you have too, Leo. And I think that's probably part of why we do these complimentary assessments for providers and for clinics is if nothing else, they're going to walk away at least knowing what tools they should have and engage in, right? I mean, it's it's just super important to understand what you're doing and how to navigate it because at the end of the day, it's still a business. Unless you're a pro bono clinic practicing free medicine, which most are not, right? It's so important to have the technology piece of it, the support piece, the contracting, credentialing, billing, it all adds up at the end of the day.
No, I get it. No, it's like without, I mean, unless you get paid, you can't serve anyone. It's what it comes down to. And what you're talking about, some of the quality measures, 10%, losing 10% of your reimbursement just because you didn't fill out some paperwork. It's kind of like paying your taxes late every year and paying a 10% penalty for not paying your taxes. You know, paying it
Yeah.
on the 20th of April instead of on the 15th or 17th, whenever it's due, just paying it a couple of days late. All you gotta do is just be a little bit, I mean, and you're talking about some of the most, brilliant people I know are in this industry.
Yep.
So it's really hard to see them losing out when they really shouldn't.
Yep. 100%. 100% right there. Well, we do. I very much appreciate the opportunity to be of service, Leo. Thank you.
All right. Thank you very much, Christian. Again, feel free to take a picture of this slide and reach out to myself or Christian, whether it's technology or a medical billing issue. One of us will be able to take care of you or at least point you in the right direction. Everybody have a great day. And before I let everyone go, we're having another webinar Thursday about AI. So if you look us up on LinkedIn, again, we'd love to have you join us about AI. It's not specifically healthcare, but it is going to be interesting. Thank you very much. And Christian, thank you. And everybody have a great day.
Thank you, Leo.